Hello everyone, this is Dr. Krishna Chaitanya. So today we will discuss about differences between bronchitis, bronchiolitis, bronchiectasis and pneumonia. So this is a small presentation, so basic differentiation between all of these. So basically BBB. So in this presentation we deal differences between their definitions, the anatomy, pathophysiology, causes of all of them, and the symptoms how they present, and diagnosis how we make up those all, and treatment how we are we going to treat all of them. So all of these syndromes or all of these clinical spectrum have an overlapping common presentations. The overlapping common presentations are usually cough, fever, wheezing, running nose. So like general coryza, like viral, any viral prodrome, which have fever, cough, and when you auscultate, you get some wheeze on chest, and they have some running nose, and these are the common presentations. So coming to the definition in peculiar, bronchitis is the inflammation of bronchi, whereas bronchiolitis is inflammation of the terminal bronchioles. So which bronchi branches into terminal bronchioles. Inflammation of that terminal bronchioles is called bronchiolitis. Whereas what is bronchiectasis? It is a chronic inflammation where that inflammation of those airways causes them some destruction permanently, getting them into dilatations, causing of lot of secretions inside that. This is bronchiectasis. Whereas pneumonia is like infection when it descends still further down into the terminal most part of the respiratory tract, which are known as alveoli. That particular site infection, we term it as pneumonia. So bronchiolitis, like as we see in the image, where the normal cartilage, normal epithelium, when it gets inflamed, they get thickened and the airway becomes narrowed due to that constriction of that smooth muscle, and that terminal alveoli get collapsed due to that constriction of that. This particular inflammation is bronchiolitis. When you come to bronchitis, it is a more upper when compared with the bronchiolitis. So the wide major airway are being involved. So that gets narrowed, that gets inflamed, so filled with secretions. So that's where you get the conducted sound, wheeze and all. So when coming to bronchiectasis, so as compared with the normal bronchus, you can see where the airway permanently gets some damage. It goes into some dilatation, fills up with copious secretions. Then pneumonia, as we told already, as we discussed, where the terminal part of the alveolar respiratory tract gets filled up with pus. So, like when coming to age group involved, we can differentiate them based on the clinical spectrum. That's what the main purpose of this presentation is: how to differentiate them clinically and with help of basic investigation like X-ray, based on the history, the presentation of the findings of the child, the symptoms given by the mother, how to differentiate them all clinically. So bronchitis usually can present with any age, whereas predominantly less than 2 years bronchiolitis and more than 2 years bronchiectasis. As we discussed, bronchiectasis is a chronic phenomenon, so definitely it develops after 2 years. Whereas pneumonia, yeah, it can develop at any age. Usually, like even newborns can get affected. Then specific symptoms. When you comes to bronchiolitis, most of the time, as we see, infants present with coryza, URTLX symptoms and all. Whereas painful cough, persistent cough, some chest tightness, these are the features which child complains with bronchitis. Whereas copious sputum production, child coughs a lot of sputum. Mother tells jars full of sputum daily, child is coughing out. That is bronchiectasis. When it comes to tachypnea and distress, child will be silent and breathing heavily, having retractions, pneumonia. So hallmarks. What are the hallmarks? So minute to minute variation is the hallmark of bronchiolitis. Like mother tells, no, kal tak bacha bahut acha tha. So child does well, all good till day before, till few hours back. Suddenly child started developing tachypnea and breathing very fast. And by the time they come to OPD practitioner, or by the time they go back home again, child appears very well. All the tachypnea suddenly decreases. We don't know. So that minute to minute variation usually happens in bronchiolitis. Why? Because this is a widespread phenomenon. If some part of the bronchioli is involved, the other part in the other lung or other lobe of the lung tries to compensate. So there will be variations. So this is highly significant and clinically potent to miss. This needs to be always doubtful, for especially for practitioners. And bronchitis, hallmark, painful cough, as we discussed already. Child will be keeping on coughing but complaining of pain in the chest or pain while coughing. And copious purulent sputum, hallmark of bronchiectasis, as we told already. They will be always copious, a lot of secretions. And cystic fibrosis and HIV infected people are more prone to develop into bronchiectasis at a later stage of life. Whereas pneumonia persists and tachypnea, and most characteristic hallmark of pneumonia is it is progressive, it worsens. Unless and until you treat, pneumonia will never get healed on its own. Something you need to treat it. Whereas bronchiolitis, like self-limiting, if you the child comes to medical attention 4 or 5 days, or else over a period of 1 week, in spite of that it is self-limiting, it goes away. So like overlap, yeah, overlap symptoms, as we told already, like coryza, fever, all are overlap. Then when we come to most common causes, bronchiolitis usually viral. The viruses most common are RSV, rhinovirus, adenovirus, coronavirus. Whereas bronchitis, rhinovirus, enterovirus, influenza, mycoplasma, bacterial pertussis. When it comes to bronchiectasis, yeah, usually viral, influenza, and bacterial, mostly bacterial, so superheated double infections, and ABPA and HIV, these are associated infections. If you come to see, this newly so-called coronavirus is causing pathophysiology of everything, starting from bronchitis, bronchiolitis, pneumonia, bronchiectasis, everything. So pneumonia can be bacterial or viral, anything. So duration of illness. The most common duration is bronchiolitis, like as we told, it is self-limiting, some 1 week, 7 to 10 days. Whereas bronchitis, it can extend up to 3 months. It is called as chronic bronchitis. And bronchiectasis, yeah, it can last for up to 6 months to years together. It is progressive. Yeah, if untreated, it causes permanent dilatation. It causes, and it is uh, completely, you cannot get it back once the child goes into that so-called cystic dilatations and tram track appearances, x-rays and all, they all are irreversible, and it is progressive. And pneumonia, yeah, usually improves within 48 hours of treatment, elsewise it deteriorates. Yeah, if you don't treat it, the child develops its complete systemic manifestations, goes into like septicemia or shock, anything. So risk factors. The usual risk factors for developing of any of these prodrome or this scenario is usually infancy, allergy, asthma, maternal infections, or immunodeficiency. So clinical examination, what are the characteristic findings specific for this particular thing? So if you see a bronchiolitis, yeah, you can see some crypts, you can have some wheeze, and the child will be tachypnea. This is the classical thing. See, you will hear both wheeze is there and even crypts are there. So this is bronchiolitis. Whereas bronchitis, if you go, mostly it is of rhonchi. There is a minor variation between wheeze and rhonchi, which you need to know. So wheeze, like it is a when terminal part of a thing is involved, whereas rhonchi is more coarse sounds which when major airways are being involved. And bronchiectasis is again here. There are coarse crackles and fine crackles where there is a differentiation. If it comes to like fine crepitations, it could be mostly pneumonia. Whereas if it is coarse crackulations with because due to heavy secretions, copious secretions, it is bronchiectasis most of the time. And another important thing is air entry, which happens usually in the pneumonia because it is a consolidation. There is reduced air entry. Then diagnosis. So diagnosis wise, based on clinical syndrome, if you may need additional imaging, radiological. So bronchiolitis is usually a clinical diagnosis, whereas bronchitis needs an additional chest X-ray, and bronchiectasis needs CT for further confirmation of the diagnosis. Whereas pneumonia, clinical and even with chest X-ray, you can differentiate whether it is lobar pneumonia or bronchopneumonia or interstitial pneumonia. So we will have a look how we differentiate based on radiological appearance and all. So bronchiolitis, how do X-ray we see? So it is usually not, it can be normal. Most of the times it will be normal, or some perihilar infiltrates or diffuse prominence of bronchovascular markings. When it comes to bronchitis, yeah, if it is acute bronchitis, you will see a normal X-ray or some hyperinflation chest or flattening of the diaphragms. Few bullae if it is chronic. Because when it goes into chronic, some that the bullae appearance, you can see it on the X-ray. Whereas bronchiectasis, how you see in X-ray, more than an X-ray, you can, it is very characteristic on CT scan, where you see that tapering of the airways with irregular wall dilatations and all. Whereas on X-ray, you can see some cystic changes, air bubble fluid levels, and tram track opacities and all. So when it comes to pneumonia, yeah, if it is a lobar pneumonia, you can see exactly which particular segment of the lung is involved. If it is a bronchopneumonia, you can see that reticulonodular opacity is diffusely scattered here and there. Whereas interstitial pneumonia, you find it as loss of lung volume and all diffuse fibrotic lung type of thing, septal thickening. You can see. So yeah, when you look at towards this X-ray, which is on the left side, yeah, this is like more of bronchovascular markings, prominence, and this is all like diffuse. You can see like a nodular head or shadow. So this is a bronchitis. If it comes to right side, yeah, it is more of like normal X-ray, just a cardiac shadow and a thymus shadow overlapping on it, and just like airway bronchovascular markings, you can see that is bronchiolitis. Then this is complete. Both the X-rays are bronchiectasis X-rays where you can see hyperexpansion of the chest and dilatation of the airways. But if you see more precise, the left side of the X-ray where are tram track appearances which you see like where there are parallel lines are starting from mediastinum and ending up to like rib cage and end of the chest. So these are tram track lines. Whereas cystic changes, you can see these are all bubbling small bubbly changes. So this is a cystic appearance. Both of these are like bronchiectasis. So pneumonia, all these are pneumonia. So this is a lobar pneumonia where a particular lobe of the lung is involved, whereas this is a bronchopneumonia where reticulonodular perihilar shadows are being seen. So whereas if you see this is an interstitial pneumonia where particularly that septae and diffuse all infiltrates type of shadows are seen. Then treatment, how are the treatment is going to differ among all of these. So yeah, if it is a bronchiolitis, none of the treatment is being recommended by AAP guidelines. Only thing they are recommended is oxygen, humidified oxygen, and 3% NS nebulization you give. Neither bronchodilators nor steroids or nor anything has been recommended by the guidelines. But yeah, off the counter many people have many different versions to use many of them, and the recommended one of the guidelines is RSV prophylaxis for high risk candidates. And bronchitis, yeah, bronchitis, because it is being painful, you have to give paracetamol analgesics. And yeah, there is a role for beta 2 agonists and steroids in bronchitis. They are the major roles of areas involved, so in order to get them dilated. Whereas bronchiectasis, yeah, because it is a permanent irreversible thing going on, they need some anti-inflammatory things and antibiotics, because the super added bacterial infections are being more common. They need antibiotic coverage too. And bronchodilators, yes, in fact, because they are all filled up with secretions in order to get cleared the airway narrowing, so they need bronchodilators. So coming to pneumonia, yeah, pneumonia antibiotics are must most of the time when it is bacterial. If it is viral, yeah, definitely there is no need of antibacterial. You can go for antiviral if they are not available. And yeah, culture specific most of the time. You send a call, and especially if the child is ventilated, the ball definitely taken out either bronchoscopically or either through suction type of thing. The culture is specific, and there are different criteria for that. And complications, what are the complications? Like each specific prodrome has different type of complications. Like if it is a bronchitis, yeah, most of the time they tend to go to develop secondary pneumonias. Whereas bronchiolitis, yeah, the child becomes tachypnic and he goes into respiratory failure. Whereas recurrent bronchiolitis episodes like 3 to 4 times within infancy childhood, yeah, there is a risk of future asthma development in such particular type of children. And bronchiectasis, yeah, this can have exacerbations because it is going to chronic copious secretions, and they are going to cause purulent, so bacterial infection. They are prone to develop lung abscesses, and because of that chronic infection, child goes into carpulmonary or secondary cardiac failure. Because of the lung pathology, the child goes into carpulmonary pathophysiology. And pneumonia, it can complicate as effusion, empyema, that all syn pneumonic effusion, and when that effusion becomes purulent, it develops as empyema, and it they get adherent to the pleura. And if it goes into disseminated systemic infection, child may develop septicemia, meningitis, shock, and even death can happen. So prevention, what are the preventive steps which you can take to prevent these type of things? So bronchiolitis, yeah, simple, hand hygiene, avoid overcrowding, and as we told already, RSV prophylaxis in high risk groups. Whereas bronchitis, steam inhalation, face mask, and humidifiers at home can prevent bronchitis. Whereas bronchiectasis, most of the time, what literature says is pertussis vaccination and measles vaccination do prevent bronchiectasis. And smoking, yeah, adult bronchiectasis most of the time is due to smoking. So avoiding smoking by the parents, even that so-called passive smoking, so avoiding smoking can be a useful thing to prevent bronchiectasis. And pneumonia, how do you prevent pneumonia? Yeah, there are vaccines available, pneumococcal vaccine, influenza vaccine. So if you use the vaccine, it's not that you never get affected by pneumonia, but it decreases the severity of the disease. And overcrowding prevention, hand hygiene, clean surroundings, and all. So yeah, this is a brief topic which we discuss today, like just a clinical spectrum, how to differentiate them, and what are the characteristic features, so that practitioners or students, when they prepare for exams, or they don't have confusion, and they know how to differentiate between each of them. And even for practitioners on their regular OPD do practice, they can know differentiate how these are there. So we will meet you very soon with another interesting topic. Thank you.